of UTI, and even just the difficulty in getting an adequate clean catch sample in an elderly person who may have limited mobility. With respect to use of antibiotics in UTI, this is a major contributor to your total antibiotic use in the long-term care setting, and UTI is the most commonly diagnosed infection in long-term care, perhaps not in influenza season, but overall the most common. We know that a lot of the antibiotic use for UTI in long-term care is unnecessary and inappropriate, and that's not unique to long-term care. It's across the board. And we know that antibiotic use, and in particular inappropriate antibiotic use, drives resistance. So I did not put in an objective slide, but what I would really like for you to take away, and this would be what would make me feel like I've done a good job, is for you to go out with the confidence to say, no, this patient does not require antibiotics. So that's kind of where I would like to go with it today. So I'm going to give you a couple of quick cases just to kind of set your mind around thinking about this. These are both fairly common circumstances. You have a 78-year-old man who's admitted to long-term care after a lengthy hospital stay for a hip fracture. He's got general debility. He comes to you with a urinary catheter. It's not clear how long it's been there, and it's not clear why it's there. This is pretty typical. Nursing staff, shortly after admission, they note that his urine is cloudy, it's malodorous, and so they send urine CNS, and you get a culture back that grows Enterobacter cloacae. And he started on ciprofloxacin, because usually you get the phone call, like, what, this older guy, he's not doing well, and he's got E. cloacae in his urine. And they want an antibiotic for him. So he started on Cipro for 7 days. Follow-up culture, he's got E. coli, and it's Cipro-resistant. Not a big surprise. So he gets Cefixime for 7 days. 2 weeks later, he's febrile, he's more confused than usual, and he's restless and has some suprapubic tenderness, and now he has both urine and blood cultures that are yielding E. coli, but now it's ESBL, so extended spectrum beta-lactamase positive. So I want to think a little bit about why did this sequence of events occur, what could or should we have done differently that might have changed that. So that's the first one. Second one is probably even more common. Elderly lady, has been in long-term care for a number of years. She's got a bit of dementia. No real complaints, but the relatives think she's declined a bit cognitively over the past month. She's not catheterized. And a urinalysis and urine culture said she has 20 to 40 white cells per high power field, and she has E. coli in her urine. Would you give antibiotics to this patient? So just to remind you of some of the risk factors, and I'm sure you're very familiar with these, age-related physiologic changes can contribute to the development of urinary tract infection. Incomplete voiding in both men and women is a huge issue. And then you may have many patients who have chronic degenerative neurologic conditions leading to a neurogenic bladder, perhaps stroke, that contribute to UTI. The biggest risk factor is catheter use. And we tend to sometimes try to use condom catheters to stay away from an indwelling catheter, but remember that condom catheters as well increase the risk of UTI, so it's about 2-fold increase in risk. So not as much as an indwelling catheter, but it's definitely a risk factor. In and out catheters can also increase the risk, but not to the extent of an indwelling catheter. And when you have an indwelling catheter, that risk is going to be affected by the duration, by insertion techniques, and by the daily management and care of that catheter. So we know with an indwelling catheter, there is an increased risk of febrile UTIs. There's an increased risk of local sort of perineal complications with prostatitis, prostatic abscesses, etc. There's increased risk of bladder stones, pyelonephritis, renal abscesses, and systemic complications. So the urinary catheter will increase the risk of bacteremia 40-fold. So that's a significant risk. And there is a risk of decreased survival in patients who have Foley catheters, but you've got to remember that risk may not be specifically due to the catheter. It may be due to all the reasons why that person has a catheter. So we don't know how much of that is a causative role, but catheters are associated with decreased survival. So if you must use a catheter, and again, you're probably very familiar with this, it should be inserted aseptically by someone who's trained. This is not the sort of time you want your youngest, newest person who's never put in a catheter before to be on deck doing it. You want experienced individuals. You want to use the smallest size catheter. You can use a small balloon rather than a bigger balloon. Rigorous attention to hand washing before and after any catheter manipulation. Maintain a closed system and keep the collection bag below the bladder. So you see these people being wheeled down to radiology with the Foley bag on the bed. That's going to increase the risk of infection. Sometimes they're on the back of the wheelchair, up above the bladder, so you can get reflux. You only want to irrigate a catheter if it's obstructed and maintain good patient hydration. There are some common sense measures that you can look at in patients without catheters as well. And I must say there's really limited to zero data to support most of these, but we know that patients who are immobile are more prone to urinary tract infections, and so keeping them as active as possible, maintaining good nutrition and hydration, optimally managing comorbidities and avoiding constipation. And I think this is probably the stuff of your days in dealing with long-term care. These are common problems in long-term care, and they're not always easy to address. Cranberry juice, well, there's very weak evidence for it. Some people say no evidence. Use of topical estrogens in women who have frequent UTIs, there is some efficacy in reducing the frequency of infection, so that's something that you may try in women with repeated UTIs. Obviously, a big focus of prevention has to be around catheters and avoiding them as much as possible, and then once they go in, having a strategy to reassess whether they're still necessary. Because often that's at the bottom of the bed, under the sheets, and you're not aware of the fact that the patient really still has a catheter in. So if they're inserted for what should be a short-term indication, you want to have a routine that will prompt you to reassess whether it's still needed. With condom catheters, one of the big problems is them getting twisted so that you end up having obstruction of the catheter, and so that will increase the risk of infection. If you can get by with in and out catheters, that would be preferred over indwelling if it's feasible. And then when you do have an indwelling catheter, being really rigorous about distinguishing what is asymptomatic catheter-associated bacteriuria from a true infection and avoiding treating asymptomatic bacteriuria. One of the key areas for prevention is if you're going to be sending that patient for some sort of instrumentation of the GU tract, make sure if they are bacteriuric that they have pre-procedure antibiotic prophylaxis. So microbiology in
Just comment about the catheters. I think it's an old adage from nursing that we do not want patients to become incontinent because it, quote, breaks down the skin. And I see that taught by the nurse instructors in the hospital. So when I ask why has that person got a catheter, it's simply they are incontinent.
Yeah.
And so I guess what I'm trying to say is maybe these people should just wear Depends. You know, I think that old
keep them up, regular toileting. Yeah.
Is not a reason for a catheter.
And there's some good posters and things coming out now around, does your patient really need a catheter? And incontinence is not one of the indications. So you can actually use that to, and if anybody's looking for that, I can provide the links for that. So the only indication where incontinence is an issue is if they have severe decubitus ulcerations with infection and you're having a struggle to get them healed, not a preventative strategy for decubitus. Yeah.
So from a nursing home point of view, the nurses do that, like the, I guess they're called the CNLs or the leaders of the unit. Do they teach that to the nurses, or is that what's happening? Ted, do we have a good
I think it's more of an issue
in acute care. Yeah.
I think it's a labor issue.
Yeah.
Okay.
Yeah.
That's why it's less work than if you have bathroom.
Yes.
Depends, et cetera, et cetera.
So
in long-term care facilities, I don't see as many catheters except people, almost like palliative. And
Yeah.
just correct me if I'm wrong, but a lot of it is people are very tuned into that. Whereas really their comfort is so compromised every time you get up to the toilet, it's painful. But the catheter will actually improve the quality of life. So
Some of the studies suggest that 10 to 15% of people in long-term care have catheters, but if we're doing better than that, I think that's fabulous.
There's going to be, I think, or is underway now, a new push towards nursing education around the identified high rate of catheter-associated infections that have been emerging. So there is going to be a push towards avoiding unnecessary catheterizations and better catheter care. I'm not sure if that's going to actually penetrate to the long-term care, but it'd be awesome if it does.
I think we're already there, though.
Yeah. It sounds like it's not as much of an issue.
Yeah, it's acute care that nurses hate catheters.
So if they
Yeah,
come back
good,
from acute
good.
catheter and they're going to be on top of
Yeah, they come back from the hospital because someone stuck it in an emerge because they didn't want to get them up to the bathroom.
So one of the catheter issues, like some of the data I've read, is that when someone has a clinical UTI with a catheter, if you replace that catheter, you significantly reduce the duration of the illness and morbidity in the catheter.
Well, it is recommended that you replace the catheter. In fact, even before you send the urinalysis and urine culture, if you think they have a UTI, change the catheter and then send the
And
samples.
this is where we need guidance from you to the long-term care facilities and also to the community where they manage people with chronic catheters, where I've asked them to change the catheter and they refuse. They're doing 3 months. Right? So I think we need infectious disease guidance to say, look, this data overwhelmingly shows that you have that.
That would come from infection control.
Yeah.
I think we get conflicting recommendations about catheter management, but it's been, based on what I've read, at least recently, my practice is leave it alone unless it's causing a problem, and usually for mechanical obstruction, that just because it's cloudy,
Didn't
or
come to
anything
that.
like
Yeah.
You know, you get calls from nurses.
Yes.
that, you know, cloudy, and you have to say, well, that's okay.
I'm actually going to address that very point. So that's very true. And nursing will look at what the urine looks like, and they will react, get a result, phone you, and then you feel like you're under the gun to do something about that. And so what I want to do is send you out with the confidence to say, no, it stops here. Yeah. So microbiology in long-term care, it's almost always or most Enterobacteriaceae. In women, E. coli. In men, Proteus mirabilis is more prevalent. Klebsiella pneumoniae is also another very common one in long-term care. I couldn't get local statistics related to specifically long-term care from the lab because we don't have it broken down. So this is not VHA data in the sense of specific to our long-term care experience, but this is what's sort of published. You can occasionally see some of the gram-positives, Enterococcus, Group B strep, and Candida, particularly for Candida in people who've been treated multiple times. So here's sort of the old way of thinking about UTI is that really a urinary tract infection is the intersection of these 3 circles. That in the middle, when you've got a symptomatic patient with pyuria and bacteria, that's kind of your slam dunk. Problem in long-term care is that we have issues with all of these. So we have difficulty in accurate symptom detection in long-term care, particularly in certain groups of patients. Chronic genitourinary symptoms are very common in the long-term care population. Asymptomatic bacteriuria is very common in the long-term population. And pyuria commonly accompanies asymptomatic bacteriuria. So this is where we have some challenges in particular in long-term care. So I think the key task in achieving rational antibiotic use in long-term care is to differentiate asymptomatic bacteriuria, which is probably the largest part of the population, from those few cases that actually have a true urinary tract infection. So the green goldfish, picking that one out from all the normal goldfish. Yeah.
That just begs the question, how do you define, not clinically, but biologically, what is a urinary tract infection?
Exactly. And there are people who call asymptomatic bacteriuria asymptomatic urinary tract infection. So there is a move afoot to transition to that. My problem with that is once you call something an infection, the next question is, what are you going to treat them with? So I would really like to stay away from that term asymptomatic urinary tract infection, even though there are cytokines in the bladder mucosa, even though there is pus cells there. And I'll explain why in a minute. So the incidence is common in long-term care, 25 to 50% of women, 15 to 40% of men. It's more likely in patients who have greater functional impairment, who are immobile, who are incontinent, and have a longer duration of stay. So what happens if we treat or don't treat? So we know that treatment of asymptomatic bacteria does not prevent the development of symptomatic infection. Okay? So treating them won't stop them from developing an infection. It doesn't improve chronic genitourinary symptomatology, and it doesn't affect long-term complications like renal failure, hypertension, and it doesn't increase, or it doesn't improve mortality. Okay? It does result in increased risk of adverse effects from antimicrobials. It does increase the risk of subsequent colonization with resistant pathogens, and these days we're particularly concerned about the ESBLs, and it does increase the cost of care. So this is a pretty clear balance here. We don't accomplish anything good by treating it, and we can do a lot of harm by treating it. So the bottom line is, if it's asymptomatic, which granted can be a challenge to determine sometimes, if it's asymptomatic, don't treat. We know that, the other people who've studied this have made really vigorous attempts to reduce treatment of asymptomatic bacteriuria. And there's evidence that show that 2/3 of patients who have asymptomatic bacteriuria, whether it's in acute care or long-term care, once you identify it, they get treated. So we have a long way to go in terms of reducing antibiotic use for this condition, for which antibiotic use does not help. So let's talk about your question about the patient with the cloudy or foul-smelling urine. We know that cloudy urine can be caused by a ton of different factors. There's a whole list there. I'm not going to go over them. But there's many different things that can cause urine to look cloudy. There's also a variety of things that give you malodorous urine. And the asparagus, absolutely. Yep, there's other foods as well. So the bottom line is that cloudy, malodorous urine, urine with sediment, these are not reliable indicators of urinary tract infection. Now the problem is, when I looked at the documents on the clinical resources site for VIHA, one of them is a document that comes from BC CDC, and it's an interdisciplinary guideline for urinary care. They actually use this as a criteria for diagnosing UTI. And that is out of keeping with all the other guidelines that are out there pretty much. So, be a little bit careful. And that's part of our BC CDC, it's actually a VIHA document that's on the clinical resources page that lists this both in catheterized patients and in non-catheterized patients as an indicator to diagnose UTI. And it's something that the nurses would refer to, I think.
Whereabouts is that?
It's under the clinical resources page on the intranet. And it's the one that is from, it's called Interprofessional CPS Guideline for long-term care for urinary tract infections. Because I was a bit surprised to see that there. So what about the patient who has pyuria, not just bacteriuria? Well, we expect to find pyuria in symptomatic UTI, but 90% of people with asymptomatic bacteria are also going to have pyuria, and 30% of people without bacteriuria will have pyuria. That can be up to 60% in elderly women. So really the main use for pyuria is to help us exclude a diagnosis of UTI. So if you have no pyuria, you can confidently exclude the diagnosis of UTI unless your patient is neutropenic, severely neutropenic. The presence of pyuria is not a rule-in test. So, and that brings us to point-of-care dipstick testing. These are not recommended for use in long-term care. They're not very accurate, and so you might as well just throw them out and not even use them at all. It's recommended that if you're going to look for pyuria, you do a formal urinalysis with microscopy, and if that is negative, then you can say this patient does not have UTI. Problem is, that's not going to occur in a lot of your patient population. The majority of them are probably going to have pyuria whether they have UTI or not. So since pyuria and bacteria are unreliable, how then do we make the diagnosis? Well, I think we can redraw this diagram and point out that symptoms are really paramount here. And that too has its challenge. So we all recognize bladder irritative symptoms, dysuria frequency, urgency. Those are pretty standard. And you may or may not be able to detect those. The caveat is they must be new or acutely increased. So if someone has frequency, and they've had it for a long time, that doesn't count. It has to be new or acutely increased. New suprapubic tenderness or hematuria in the absence of a catheter. Those are good signs. With upper tract involvement, again, new or acutely increased flank pain or tenderness. And then, of course, the systemic symptoms, which are nonspecific. And I'll point out here, I put a greater than 38 degrees centigrade, but remember, elderly people may not mount a temperature, and so an increase of 1.1 degrees centigrade over baseline can be used as a parameter, but just remember there's a diurnal variation during the day that can be as much as a degree. Celsius, and so you need to know sort of maximum, minimum temperatures for that patient before you decide if they've had a significant increase. So if you have a symptomatic UTI, then you're going to look for the pyuria, because if it's negative, you can rule it out. You're going to look for bacteriuria, so a positive urine culture of at least 10 to the 8th colony-forming units per liter with no more than 2 species. Okay, so once you start to get to 3 species, that's a contaminated, or it's highly likely to be a contaminated specimen. Elderly patients may have lower colony counts compared to younger people, and this, sorry, that should be, that's in per mil, not per liter. I realized you guys here use per liter, and so I changed the one and forgot the other. But elderly patients may have lower colony counts, so that can change things a little bit. The problem we have is with catheterized patients, they don't have those typical symptoms. So the things you're going to look for are bladder spasms, bypassing the catheter, suprapubic discomfort, and if they're spinal cord injured, increased autonomic dysreflexia, spasticity, bypassing again, and just a general sense of dis-ease has been reported as being associated with UTI in that population. Now, what about the dementia patient? This can be really challenging when the patient can't identify localizing symptoms. So quite often you'll have a patient who's got a little bit of increased incontinence, maybe they're a little more confused or agitated, or they have increased what are called responsive behaviors. You're all, do I need to define that? No? Yeah?
Do it. Yeah.
So it's behaviors that indicate that the patient has some sense of things not being right, some unmet need, something that they're reacting or responding to and trying to communicate, but not able to communicate in a way that would be specific. So the problem is those symptoms are all nonspecific, and usually they aren't due to a UTI. So the bottom line is we really have to go and do a careful physical assessment to identify any truly localizing symptoms. We have to do a thorough search for other causes, so UTI now becomes a diagnosis of exclusion rather than a go-to diagnosis. And I know a lot of times when you see these patients in Emerge, and in my past life working with residents in emergency, UTI was always the go-to diagnosis when they're in a hurry, got a sick older patient coming in who's a little more confused. Oh, they've got pyuria, UTI, diagnosis done, off to the ward, and that's the end of the story. In fact, when you get this, you need to spend more time working that patient up, looking for other causes. And a lot of documents suggest that you trial a period of enhanced hydration before committing to treatment with these people. If they're not that sick, try pushing fluids for 24 hours and reassessing them and seeing if they get better. Similarly, the patient with bacteriuria who just is, the old term failing to thrive, just not doing well. UTI has been shown to be the cause of this in only 11% of those patients. And fever is almost always present when it's due to UTI. So again, this would be UTI is often the go-to diagnosis here, but in fact it's the uncommon diagnosis. What about the patient who has bacteriuria and has fever? So in the absence of localizing symptoms, this is only due to UTI 10% of the time. So the sort of things that you might look for in this situation to increase the likelihood of it being UTI are hematuria, acute retention, catheter obstruction, flank pain. So those are the features you might want to look for. So diagnosis is a challenge, and this is a particularly challenging population, and we don't want to be so strict with treatment that we miss treating people who need it. But I think we've got a lot of room to be a little more rigorous about saying, this patient does not need treatment. And sort of kind of responding to the pressure that you might be getting from the staff on the ground to say, put this patient on an antibiotic by saying, let's try something else first, let's reassess, and so on. So how do we treat? Elderly women in long-term care tend not to respond as well to the short sort of 3-day courses, so you may want to extend it up to 6 to 7 days for lower urinary tract. For upper tract, 10 to 14 days, and for men, 10 to 14 days. Men who have symptomatic relapses within 6 weeks, you may want to assume prostate infection and treat for 6 to 12 weeks. I'm a little bit uncomfortable with doing that the first time around because that's a long course of antibiotics. But again, you want to go back and do the exam and check and see if there are other features that would support that decision. So with treatment, number one, confirm that it's symptomatic. Send the lab-based urinalysis and culture. If they're medically stable, you can push fluids for 24 hours and reassess. There's also a recommendation in long-term care that if they're not acutely ill, you defer treatment until susceptibility results are available, because the susceptibilities may be less predictable than in the community. So Carson already mentioned this, but some cautions with your antibiotic choices. Watch for drug interactions, and this is where the quinolones become an issue. You want to look for reduced urinary function or renal function and adjust your doses. And in the elderly, remember that some adverse effects are more common. Confusion being one of the big ones with the quinolones we see fairly often. So uncomplicated cystitis, and I think you guys probably all know this very well, but your main options are nitrofurantoin, keeping in mind that this is only good for lower tract disease, and you need to adjust if there's renal failure. It's not going to work with Klebsiella proteus, Morganella, so some of the ones you might be seeing. Cotrimoxazole. E. coli is not as sensitive as we would like it to be for sort of frontline use, and cotrimoxazole does not work for Enterococcus often, or it may not work for some of the Enterococcus. Amoxiclav, not a bad idea, not a bad choice. You can use Cefixime as well. The upper tract disease, cotrimoxazole or amoxiclav, and then look at whether or not you need to transfer to acute care based on the patient's clinical features and their wishes. Cipro tends to be a first-line choice for a lot of UTIs, but our resistance rates for E. coli are too high to recommend it as first-line. But where you might want to consider using Cipro is if you get an Enterobacter, Citrobacter, some of these more uncommon organisms, or Proteus, and Pseudomonas would be situations to consider using Cipro. So one of the things about UTI is that we expect patients to quickly develop recurrent bacteriuria after treatment. So 50% of both men and women are going to have positive urine cultures again within 6 weeks. So the bottom line is, don't retest. Okay? You don't test, you won't have someone pressuring you to put the patient on treatment. So if they're asymptomatic, don't send a follow-up urine culture. If they have indwelling catheters, and this is really where we see even greater challenges, 100% of people are going to have bacteriuria at 30 days. And there's often multiple organisms that will be present. And what you'll see is if you culture those people over time, repeatedly, they'll just cycle. So this week they might have E. coli, 2 weeks later they might have Klebsiella, and then a week later they might have Enterococcus. So you are going to have organisms there, and those populations are in the biofilm on the catheter, and they're going to wax and wane over time. And when you culture through that catheter, what you're culturing is biofilm microbial communities, not organisms that are in the bladder or on the mucosa. And so this is where, if you are going to culture a patient who you think has a UTI and they have a catheter, removing the catheter first and culturing from a freshly inserted catheter is considered a better choice. So to diagnose catheter-associated UTI, you want a catheter urine sample which has significant bacteriuria and at least one of those clinical findings. So fever, rigors, or new onset of hypotension, so somebody who's behaving as if they have urosepsis. Acute change in mental status with leukocytosis and no other cause. So again, we're being fairly restrictive about using mental status changes as an indicator of UTI. New onset of suprapubic, flank, or pelvic pain or tenderness. Purulent discharge around the catheter, or acute pain, swelling, or tenderness of the testes, epididymis, and prostatitis. So you need to have both. The urine sample positive and at least one of those clinical findings. I would be a little cautious about saying pus around the catheter alone is a sufficient indicator, because you do often get some purulent discharge, especially in people who may be irritating it, pulling on the catheter, so keep the context in mind. Again, don't treat asymptomatic patients. Change the catheter both to reduce the bacterial load in the biofilm and to get a better sample, and limit the treatment to 7 days. And again, don't retest post-treatment in a patient who's asymptomatic. So So I just want to wrap this up with some sort of the basic take-home points that I think will help you have the courage to say no and the conviction to say no when maybe you're getting some pressure, either from family or from nursing staff. The urine looks cloudy, it smells bad, mom must have a UTI, can't you put them on an antibiotic? So remember that the diagnosis depends on localizing genital urinary symptoms, a positive culture, and that the absence of pyuria, if you're so fortunate as to get that, excludes a diagnosis of UTI. Fever in a patient with bacteriuria and no localizing genital urinary symptoms, 90% of the time that's going to be another cause, so keep looking. Chronic GU symptoms are common in the elderly, so we only accept acute changes in those symptoms as relevant to the diagnosis of UTI. And non-specific deterioration should not be attributed to UTI unless there's fever also present, and we've excluded other possibilities. Presence of bacteriuria with or without pyuria is not adequate for the diagnosis, and so we really need to look at that careful assessment of localizing symptoms. And then treatment of asymptomatic bacteria has no benefits but does have risks. So in asymptomatic individuals, don't screen. Don't send cloudy or foul-smelling urine, and don't send routine post-treatment cultures. I think your hand.
I just want to share a point and ask a question, or share some experience. What we do in our office, because I just do exclusively home-based geriatrics and facilities, and we get about 2 faxes a day. With the nurse in the community has dipped the urine and it's positive and sent it off, the person has a standing order for urine, or the facility has done it. And our MOA has instructions to immediately fax back to them. Does the person look sick? There's a couple of questions. Do they look ill? Number 2, is there new confusion or change in confusion, for the facilities? Number 3, do they have fever? Number 4, do they have new lower tract symptoms, new burning, new frequency, new incontinence? No, 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 don't worry about it.
And that's a systematic approach to try to help.
And it cuts down the antibiotics, and we will then only treat, and then I'll wait for the sensitivities to come back unless if they come back and they're sick, you may want to start treatment, but otherwise.
I think that's a good sort of institutional strategy.
And the MOA can do it, MOA can do it.
Yeah.
The other thing I was just going to ask you about the dipsticks. The labs will not even culture urine unless there's leukocytes or nitrites on their dipstick. So you made a comment that the dipsticks are useless. I guess I would say in the real world.
So let me caveat that by saying that in long-term care, so point of care is where they have not been found to be accurate enough to do anything on that basis. So when you send it formally to the lab.
Yeah, I'm talking about like the decision to screen. Like we have nurses who go into homes. And if the dipstick is negative, we don't send the urine off to the lab.
Yeah, absolutely.
But if the dipstick is positive, then we'll send it to the lab.
And send the urinalysis
exactly.
as well. Yeah, and that's a very appropriate strategy.
I just had a question about, I work in hospice, so we have severely compromised patients. And when we've had patients with recurrent UTIs, and say they have an indwelling catheter, do you have a recommendation for ongoing like prophylaxis antibiotics for those patients who we've found will become acutely decompensating?
So I started this in because I kind of anticipated the question, what about a patient that's got a chronic catheter? The evidence shows that prophylaxis doesn't reduce the risk of infection, doesn't reduce asymptomatic bacteriuria, and there's a 2-fold increase in antibiotic resistance in the infections that those patients who get an infection get. So my worry is then you end up merging over time as you keep treating those people. Basically, you get more and more resistance, and eventually you get to ESBL, where the only option, or one of the few options, is going to be ertapenem, intravenous, and even some of those becoming further resistant from there. And so, I think I would focus on maintaining best practice for catheter care, maintaining hydration to sort of reduce the risk, and then having a fairly careful process of assessing when do you actually need to treat versus when is this just chronic catheter colonization.
And so with the first comment about does not significantly impact incidence, do you have any sense of like what that would look like? Because I guess you know, we've got patients who, you know, likely have some short months. So probably, you know, we're not really looking at the longer term impact of this person getting ESBL, because we're not going to treat them with IV antibiotics. So they may just be on oral antibiotics until they lose the oral route, and then we just stop it. So I'm just curious, would there be like so little benefit in doing that that's not even worth doing?
I think the risk side is that it's not just about resistance in an individual, but resistance in a community. And so, you know, you've got to balance, you know, obviously you have to balance the patient's need for comfort and making their last days as good as they can be, but remember that the whole community is impacted by the emergence of ESBL and things like that. So it's a tough call. And, you know, there may be patients where you really think, sure, a little nitrofurantoin, maybe that's going to help. The problem is that because of the characteristics of biofilm, you're usually going to end up with very quick development of resistance, more complicated pathogens that are just going to make it more difficult to treat over the long term. I'm sorry I don't have numbers, but.
Any indication that the degree of pyuria is of any help? Because I think there's this tendency to see greater than 100, and presence of nitrites as kind of, whoa, you know, this may be indication to start an antibiotic while waiting cultures.
I think the indication to start an antibiotic is symptoms. Can you identify symptoms and signs, not how much pyuria there is?
Which sort of goes back to my question, what is an infection? It's when your body is responding.
Exactly. And you know, I'm sure that it isn't, this box is asymptomatic bacteria, and this box way over here is treatable UTI. There's going to be some gray areas where people maybe have very mild symptoms, and I think that's why the idea of giving them 24 hours of hydration, aggressive hydration, probably has some benefit, because maybe those people are going to have enough of a response with just increased urine flow that they're going to revert back to a true asymptomatic bacteriuria.
Can I see the
Oh yes, you can have
all right,
that.
our next
last
one.
question.
Sure.
A fever, is that only from kidney infections? Can your bladder infection cause fever?
No, lower tract infection should not cause fever by definition. So bladder infection is a surface mucosal involvement with no systemic, should not have systemic effects. So if you have a fever, you need to be thinking about pyelonephritis, upper tract, or prostatitis, acute prostatitis. Yeah.
Okay, that's what I thought.
Yeah.
Thank you.